Surgical resection, or when you're cutting surgically the limb, this is called as amputation. Amputation is a big stress. It's a big psychosocial, plus it's a physical stress for the patient. So, but usually those limbs which have already suffered irreparable damage, or owing to the trauma or atherosclerotic disease or the peripheral vascular disease, most of the time amputation is done because if we talk about the peripheral vascular disease, if we talk about the gangrene, or if we talk about the cellulitis, these are the widespread phenomena which usually extend distal to proximal limb of the body. So if we do not amputate that particular limb, usually there's the chances that the infection or the cellulitis or the gangrene that will extend from distal part of the body to the proximal part of the body. So that's why usually this is performed in the conditions that are unavoidable, and they're performed in the best interest of the patient. If we talk about the amputation level, this is somehow very much important when you are determining the amputation level, because you have to balance between the function of the limb plus the complication. Like if you are convinced for a more distal amputation, then you have to balance this distal amputation with its increased function with the proximal limb amputation with associated with less likely risk of complication. So the distal amputations, they are usually performed because to restore the function of the limb, because if the amputation level is at the level of the knee or distally to the knee, then the process of the walking, the function can be restored by the use of the prosthesis. But if the amputation is more proximal, like the amputation is at the level of the hip or at the level of the femur, which is particularly called as above knee amputations. So in most of the time, the prosthesis fitting, it's a kind of the challenge for the patient, and you cannot restore the patient's function of the limb. But particularly, you have, again, I'm telling you that you have to weigh between the functional restoration with less complications. So if you're more concerned about the mobility, or you're more concerned about the function of that particular limb, then obviously you'll go for more distal amputation. But if you're more concerned about the proximal, more concerned about the risk of the complications, or you're not concerned about the functional restoration, in case of the old age people, we usually compromise the function of the limb because they're mostly bedridden, and association with the other metabolic and the systemic disorders also matters. So with the low risk of the complication, more proximal amputation is involved. But if you talk about the level of the amputation, there can be, like, if the amputation is at the level of the neck, this is called as a 4/4 amputation, particularly if there is a kind of the trauma. Most of the time, if we talk about the upper limb amputations, we actually divide these amputations in two important categories. One are the upper limb amputations, and others are lower limb amputations. Most commonly, lower limb amputations are usually performed because the peripheral vascular disease and diabetes and the gangrene is involving more of the distal vasculature as compared to the proximal. So if we talk about the upper limb dislocations or the upper limb amputations, so apparently they're more commonly associated with the traumatic, they're mostly the traumatic amputations. So these involve the 4/4 amputation, shoulder disarticulation. At the level of the elbow, this is elbow disarticulation. So there can be above elbow amputation and below elbow amputation. You can see if it's at the level of the midshaft of the humerus, this is the above elbow amputation. And at the level of the elbow joint, this is elbow disarticulation. And below the below the elbow joint, and just in the middle of the forearm. This is below elbow amputation, and mostly the traumatic incidents involving the hand and the wrist, they are particularly meant for the hand and wrist disarticulation. These mostly these are the amputation levels. If we talk about the shoulder, if we talk about the upper limb amputations like the shoulder disarticulation, elbow disarticulation, forequarter amputation, above elbow amputation, below elbow amputation, and hand and wrist disarticulation. One thing to remember is that most of the upper limb amputations are because of the trauma. Now, if we talk about the lower limb amputations, there are some different kinds of the amputation levels which are available with us, like the hemipelvectomy, like the half amputation is at the level of the pelvis. The other one is hip disarticulation. At the level of the knee is the knee disarticulation, and above, if the articulation is above knee, this called as above knee or the transfemoral, because you're going through the femur, so that's why it's called as above knee or the transfemoral amputation. Just 10 centimeter or 10 to 15 centimeter below the tibial tuberosity. These are the below knee amputations. They're also called as a transtibial amputations. If we talk about the ankle joint, then at the level of the ankle joint, there are ankle disarticulation, and below the ankle, there are transmetatarsal or the distal amputation, which are the partial foot amputations, and usually there can be a single. Like if the big toe is involved, the big toe amputation, or whatever the finger is involved, the finger amputation. So there's another, which is the Symes. They're kind of the processes which are involved in the procedures, particularly called as a Symes amputation in case of the foot amputations. But most commonly, because I have already told you, if we talk about the peripheral vascular diseases, and if we talk about the diabetes, mostly the level involved is usually from distal to the proximal part of the limb. So in our setting, most of the time, there can be partial foot amputation, there can be toe amputation, there can be ankle disarticulation, or there can be knee disarticulation, above knee or below knee amputations. But usually those processes which have already got extended to the level behind this, then hip articulation, disarticulation, and the hemipelvectomy are usually the procedures or the choices which are available with us. So again, talking about our main focus today will be on lower limb amputations. So we'll be talking about the hemipelvectomy, the kind of the amputations which involve the lower limb, the hip disarticulation. Then, there are most commonly the procedure performed are like above knee amputations, which is ABK, and the other is a below knee amputation, BKA. So ABK and the below knee amputations, they're most commonly performed. But usually, if the functional restoration is important, or the process like the gangrene and cellulitis has still not extended to the upper portion of the upper thigh, then usually the option we have available is to go below knee amputation. But most commonly, in today's setting, through knee amputation or knee disarticulation, they're also commonly performed procedures in today's setting. So very short above knee, short above knee, medium above knee, long above knee. These are all the levels of the amputations. But most commonly, we usually perform below knee amputations or above knee amputations. The other one is a knee disarticulation, as you can see in your diagram. If you are going 10 centimeter, usually the margin is like 10 to 15 centimeters below the tibial tuberosity in case of the below knee amputations, and the margin for above knee amputations from the tibial tuberosity is 20 centimeter. So for above knee, it's 20 centimeter from the tibial tuberosity, and for below knee amputations, it's usually 10 to 12 centimeter below the tibial tuberosity in case of the below knee amputation. Then you have the standard below knee amputation. There's a short below knee amputation. There's also this short below knee amputation. This is also called as a you're performing through knee amputation, right? And standard below knee amputation is a transtibial amputation. And at the foot, there are Symes, there are hind foot, such as the void amputations, and then you have the toe disarticulation or amputations if we talk about the lower limb amputations. So now the question is, why you are performing the amputations? Like, what are the kind of the indications which are usually because of that it ended up in the amputation of the limb? So we divide this in three broad categories. One is a dead limb, one other is a deadly limb, and the third category is dead lost limb. So in case of the dead limb, usually we define the limb that has already reached up to the level of the gangrene, right? So and the other is a deadly limb. And in case of the deadly limb, like the process of the gangrene is like, there's a putrefaction and the moist gangrene, and there's more chances of the infection of that particular limb. So that's called as a deadly limb. So in case of the deadly limb, like the moist gangrene, and most of the time the infection and the putrefaction is spreading to the surrounding tissues, like the most viable tissues already gone up, like in case of the cellulitis, or they can be atriovenous fistula. So they all constitute the group which is called as a deadly limb, and there can be some malignancy like the osteogenic sarcomas or like the Ewing sarcomas. They are categorized in the category which is deadly limb. Then there's a dead lost limb. Like dead lost limb is a kind of the the kind of the limb in which the gangrene, or there is no focus of the vascular compromise, but there's a severe rest pain, and with unconstructible critical leg ischemia, or there's a paralysis, or already there's a contraction or trauma. So these are the indications for the amputations. Like we've broadly categorized into three categories. One is a dead limb, like the limb has already dead, and because of there's no vascular supply, there's no blood supply, and the gangrene has already developed. In case of the peripheral vascular disease, or in case of the diabetes, the gangrene has already developed. In case of the deadly limb, already the gangrene is there, but the full-blown gangrene has not yet developed, but there's a moist gangrene or the dry gangrene, which is also associated with the cellulitis, the putrefaction or the infection of the tissues, and that infection is involving the viable tissues. So because you have to save the viable tissue, because if you do not amputate that level, then the infection or the putrefaction will spread proximally, and the viable tissues, they will also be involved. So because of that, amputation is the indication in that particular case. Like wet gangrene, spreading cellulitis, there can be gas gangrene, there can be some arteriovenous fistula as well, and some malignant tumors like the osteogenic sarcoma, or there's like the Ewing sarcoma, in which the bone is already eroded and the viable tissue has already been metastasized. And obviously, if you do not amputate that level, it's not about only the osteogenic sarcomas. There can be some carcinomas of the skin which are extensively involving the skin, and they're extending deeper down into the tissue. So most of the time, like the squamous cell carcinoma, like the basal cell carcinoma of the skin, they're also the indication for the deadly limb. In case of the dead lost limb, there is without the gangrene or without the vascular compromise, there's still severe severe rest pain, which is usually, there's not reconstructible critical leg ischemia. So in case of the unreconstructible critical limb ischemia, there's a severe pain, and that is also the indication for the amputation. Now, the other thing is the paralysis, the limb which has already undergone the trophy, or their contractures after the trauma, because whenever there's a wound healing, the process of fibrosis goes along with that. So because of that, some contractures like the trauma, and already you're unable to save the limb. So all these these are the indications for the amputation of the limb. Now, if we talk about the lower limb amputations, the distal and the transmetatarsal amputation, before that, I want to talk about some general principles for the amputation. First, at the determination level, I have already told you that you have to determine the level of the amputation, the level of the disease, and the level of the vascular supply. Let's suppose that you are, apparently there is a gangrene, and the gangrene is extending to the mid-thigh, and still you are thinking that you should go for the below knee amputation or just slightly above knee amputation. You're not you're convinced that you should not go for the hip disarticulation, or you should go for the hemipelvectomy. Then what is a choice available with you? And you try to palpate the femoral pulse, but the femoral pulse is not palpable. So in that case, if you do the above knee amputation at the level of the mid thigh, and then what happens is and you try to save the rest of the limb for a good prosthesis, but the thing is there is no femoral pulse palpable. So if you even leave the stump, the question is there's no femoral pulse palpable, there's no blood supply. So even if that particular stump is already left behind, there is no good vascular supply for the limb, and ultimately it will be converted into a dead limb. So determination of the level of the amputation, determination of the extension of the disease is somehow very, very much important. So talking about the general principles, always remember in mind that you start from the skin. You're more concerned about the skin flaps, and because you try to restore the stump in a good figure, or the stump is favorable for the prosthesis, because if you want to restore the function of the patient, or the function of the limb, that's how somehow this is important for, even if you're talking about the young people, they're more concerned about their limb function. So in that, you have to take care of these things. Plus, first of all, you have to make the skin flaps. You have to excise the skin, the subcutaneous tissue, and a good bulk of the muscle should be left behind, so that the skin flap should be traced back, and it should be sutured with the periosteum of the bone. The other thing which is important is that you can make the anterior posterior flaps equal, or you can go for a long posterior flap and a short anterior flap for a good stump. This is a general principle. Now, if we talk about the general principle for the amputation levels, you should remember that the margin below the knee, in case of the below knee amputation, that should be 10 to 15 centimeter below knee, and the landmark is the tibial tuberosity. And if you talk about above knee amputations, the level should be 20 centimeter above the tibial tuberosity. So again, this is a general principle. Then, if you're constructing a muscle flap, you can go for a myoplasty, or you can go for a myodesis. So in case of the myoplasty, if you are reconstructing the muscle with muscle, then this is called as a myoplasty. And if you're reconstructing the muscle with the connective tissue, or you suturing the muscle with the bone, this is called as a myodesis. So myoplasty and myodesis, they're the procedures which are usually used for the reconstruction of the muscle. So myoplasty is what actually you are repairing the muscle, and and you are suturing the muscle with the muscle. This is myoplasty. And if you're suturing the muscle with the connective tissue, or you're suturing the muscle with the periosteum of the bone, this is called as a myodesis. All the vessels should be ligated whenever you're performing the amputation, and you should keep in mind, if you're talking about the particularly lower limb amputations and you're talking about below knee amputations, then all the posterior tibial artery and the peroneal artery, they should be ligated well. If we talk about the general principle for the nerves should be cut sharply. They should not be ligated, because most of the time if you ligate a small nerve, there's a chance that neuroma will develop, and it would be causing a lifelong pain for the patient after the amputation. So that's how it's important. And then you are also sharply cut the vessels and allow them to retract, particularly nerves, ligate the arterial supplies, ligate the vessels, and then large vessels, large nerves, they can be ligated, and then flap suturing, reconstruct the flap for a good stum. Either anterior posterior, equal anterior posterior flaps, or long posterior flap and the short anterior flap. We'll be talking in detail about all this. Now, the thing is, after you're done with the amputation, then you have to put the drain, and you have to give a good support. First, like if you put the drain, you have closed the stum. If it's not infected, then you have to close the stum, and then the bone should be beveled, because if the bone is not beveled, it's going to cause the damage to the vascular supply of the muscle, and there would be necrosis of the stum, and the prosthesis wouldn't be effective, and later on a more proximal level of the amputation would be required, and you have to again do the amputation. So this is somehow very much important. At the end, you have to give a good support to the limb, keep the limb elevated, a bandage, a soft cotton roll gauze bandage, then the cotton bandage. And sometimes, secondarily to the trauma, if your amputation is because of the traumatic incidents, then you have to apply the back slab as well. And then at the end, you have to cover it with a crepe bandage, and you have to keep the limb elevated to avoid the stump edema. And you have to care about the post-operative care, pre-operative preparation, and the post-operative care. They're somehow very, very much important, because the post-operative complications, specifically if the phantom limb is already developed, that's a kind of a stress, and the feeling of a pain in the amputated limb, that's kind of a stress, and you have to give a good psychiatric counseling to the patient, because it's a kind of a social stress, and patient is unable to move about in the society. So the social trauma, it's a kind of a psychological trauma. So for that, you have to give patient good post-operative care. So now talking about the distal and the transmetatarsal amputation, they're involving mostly the distal part of and mostly if the gangrene is involving the first toe or the fingers involved and they're extending metatarsally, then the level of the amputation is like mid-metatarsal. The metatarsals are divided into head, neck, and the shaft. So usually the level of the amputation for the more distal amputations of the transmetatarsal, the level of the amputation should be, these are the it can be a metatarsophalangeal amputation, right? So in case of this picture, you can see it's a kind of the amputation which involving the whole of the 5 fingers, and the level of the amputation is interphalangeal. But if you go behind that and you try to amputate the limb at the metatarsal point, then this is the transmetatarsal amputation or more distal amputation. So in case of the major amputations, if you have already determined the level of the amputation and you're already confident about the spread or the extension of the disease, now you have to make the good choice for the operation, keeping in mind the restoration of the function of the limb and keeping in mind the availability of the prosthesis or the good available stump for a good prosthesis. So majorly there are three operations in particular. You're talking about the lower limb. There are above knee amputation or below knee amputation, and the other is through knee, or this also called as knee disarticulation. So the above knee choice is transfemoral operation, and the below knee choice we have is the transtibial. So the transtibial is particular, like because you have to cut the level, like it's usually 10 to 15 centimeter from the tibial tuberosity. And if you're talking about the above knee amputations or the transfemoral, you have to go through the femur, and that should be like 20 centimeter above the level of the tibial tuberosity. So first we'll be talking about the below knee amputations. So there are two methods for the below knee amputations. One is the long posterior flap, and the other is a short long posterior flap and a short anterior flap, and the other is both anterior and the posterior flaps, they're equal, which is called the skew flap. But you know, the level or the choice for the long posterior flap or the skew flap choice, that depends upon the ischemic or the non-ischemic limb. So usually in case of the non-ischemic limb, you can perform both anterior and the posterior, if both the anterior and the posterior flaps are equal. So that can be performed in case of the non-ischemic limb plus myoplasty or the myodesis. Both are the options we have available for the non-ischemic limbs. But particularly for the ischemic limbs, the care should be taken that you can only perform the myoplasty. You cannot perform the myodesis, because in case of the myodesis, you are suturing the muscle or you're pairing the muscle with the periosteum of the bone. So in case of the ischemic limb, vascular supply is already being compromised. So if you're trying to suture the flap with the, or you're suturing the muscle flap with the periosteum, there's a chances to develop more of the ischemia. So in case of that, you go for the myoplasty. You don't go for the myodesis. Plus, if you talk about the flap of the skin, then the best choice for the ischemic limb to keep the long posterior flap and keep the short posterior flap. So in case of the below knee amputation, if you're performing the long posterior flap, again you have to keep in mind the general principles. Vessels should be ligated, myoplasty or myodesis should be performed. In case of the ischemic and non-ischemic limbs, obviously the choice would be different. You will not be performing myodesis in case of the ischemic limb. And plus, the nerves, they should be sharp. They should be sharp cutting, and they should be allowed to be retracted. The larger nerves can be ligated, but usually if you ligate the smaller nerves, there's a chance for the development of the neuromas, and then these neuromas, they cause lifelong pain. So the landmark, if you could appreciate in this diagram, this is the level of the knee, the patella, and you have to identify the tibial tuberosity. If you've already, this is the level of the tibial tuberosity, right? This is the knee, and usually tibial tuberosity is 2.5 centimeter below the level of the patella, and at this level, you mark the tibial tuberosity. And after marking the tibial tuberosity, you mark a 10 centimeter line from the tibial tuberosity. But usually the margin, the safe margin, or in case of the long posterior flap, up to 15 centimeter, the length of the 15 centimeter, up to 15 centimeter is enough for a good long posterior flap with a good vasculature. But a flap, usually less than 10 centimeter, that's not sufficient. And obviously when you're constructing the flap, the stump would not be equal, and obviously at times the stump goes off into necrosis. So the thing is that you mark this line, you mark the tibial tuberosity, and you mark the distance from the tibial tuberosity, like 10 centimeters. Some people are more comfortable with 12 centimeter, or some are more comfortable with the 15 centimeters. So keep in mind the range for that is 10 to 15 centimeter, and the ideal length should be 12 centimeter from the tibial tuberosity. When you're already done marking the tibial tuberosity, then what you do is you take a long suture tie and you measure that 10 centimeter and you divide it into two halves. Then what you do is you have to measure this circumference, and you keep 2/3 from the anterior aspect to the lateral aspect of the thigh, and the 1/3 is extended below, and then that's how the flap is constructed. As you can see here in this picture, you have already marked the tibial tuberosity. You have marked a 10 centimeter line anteriorly from the tibial tuberosity, and then what you're doing is like you're extending this to both the medial and the lateral aspects, and 2 centimeter lateral to the tibial crust, you go right here and you extend this vertically downward, and then you go behind and you complete the circle. That's how a long posterior flap is created. This is somehow a very difficult idea and a very difficult technique to understand, but the thing is, first you should keep in mind the steps you're performing, right? Mark the tibial tuberosity first, then mark the 10 centimeter or the 12 centimeter, the ideal length for the stump, extend it medially and laterally, extend it downward vertically here, almost 1/3 and 2/3, and then that would be the shape, right? So you are keeping the long posterior flap with the good muscle bulk. Like you can resect the soleus, but the gastrocnemius is left behind, so that there should be a good muscular flap available. And then that's how the anterior flap comes out to be, and this is the posterior flap. Now what you do is whatever the vessels which are coming in your way, that you ligate the vessels, and in case of the medially you have the saphenous nerve and laterally you have the sural nerve. So what you do is you try to cut sharply the smaller nerves, and the larger nerves can be they can be ligated. And after that, what you do is you tie the muscle with the periosteum. You bevel the bone so that the sharp edges of the bone, they are smoothened enough to restore a good vascular supply. And then you suture the muscle, the bulk of the muscle, of the muscular flap, with the periosteum of the bone. That's how a long posterior flap. Now, the general principle for all the amputation is the same. How you have to ligate the vessel, how you have cut the muscle, or how you have sharply cut the nerve knot. The principle for all the amputations remain the same. The concept is to make a good skin flap so that there would be enough stump available for a good prosthesis. So in case of the baloney amputation, there are two choices available with you. One is a long posterior flap, and other is a skew flap. So for the non-ischemic limb, you usually perform the both skew flaps, like both anterior and the posterior flaps. They're usually equal. But in case of the ischemic limb, you have to keep the long posterior flap and a short anterior flap, and the rest of the procedure remains the same. So you can see here in the diagram that there was the anterior part. This was the tibial tuberosity. You mark a greater length available for the stem. This is the long posterior flap. And what you're doing, that after you're done with the myoplasty, you're done with the myodesis, the nerves are already retracted, you have already ligated all the vessels, and you have tied or sutured the rest of the muscle flap with the periosteum of the bone. Then what you do is you bring the flap just from posterior to the anterior position, and you try to chisel them up, keeping the drain inside. And the other thing, most of the people, they prefer to put epidural inside that, so that after post-operative complication of the phantom limb, they can be avoided. So you can place a good epidural along with the drain in the stump. So that's how the long posterior flap is done. There's another flap which is, becoming very famous day by day, which is a Q flap. And in case of this Q flap, again, the basic principles for the amputation, they remain the same, but you mark, instead of the tibial tuberosity, you mark it from the tibial, the crest, right? So actually you mark the 2.5 centimeter, this is the tibial crest, and you take a measurement 2.5 centimeter away from the tibial crest, and you extend it downward, and you try to make the long suture that's divided into two halves, and then that divided into four halves, and that's how you measure the anterior and the posterior flaps. So that in case of the Q flaps, both the flaps for the anterior and the posterior parts, they are equal. They, like in the process we have discussed before, you were keeping the posterior flap long and you were keeping the anterior flap short. But in case of the Q flap, both the anterior and the posterior flaps, they are usually equal. In case of the above knee amputation, like if you could appreciate here, this is the femur, this is the tibia, and this is the fibula. But what you do is, in case of the below knee amputations, you divide the fibula 2 centimeter proximal to the level of the tibia, right? So for the above knee amputations, the level is like, it can be a mid at the level of the mid femur, or it can be at the level of the neck of the femur. So it depends upon how far the disease process is extended and what actually the level of the amputation you need. So in case of the above knee, the incision remains the same. The Q flap, again, you give incision to the mid shaft and you go through the femur, and you keep the long anterior and the posterior flaps just similar to the above knee amputation. That's how the stump looks like when you're performing the above knee amputations. Most of the time, above knee amputations are performed in which the femoral artery is usually not palpable, and you're not very confident if you do the below knee amputation, the stump would survive or not, because you need a good vascular supply for the stump. But if you do not palpate the femoral pulse, and there is no femoral arterial supply available for the stump, then obviously there would be necrosis, and ultimately it will end up in more proximal amputation. Now, there's another thing which is somehow very much important, and it's becoming famous day by day, that is through knee amputation. And in case of the through knee amputation, the level of the amputation is usually, it's like you're saving the femur, you're saving the full length of the femur, you're saving the full length of the patella, and you are going just below the patella, and the level is like 3 centimeter below the tibial tuberosity. As you could see here in this diagram, that this is the full length of the femur, right? And this is the patella over that, and from this point the tibia is being started. So you can do either through two things. One is like you do the knee disarticulation, like you go through the joint. If you go through the joint, then you don't have to cut the you don't have to cut the tibia, you don't have to cut the femur, and you don't have to cut the patella. You actually go from the space which is present around the knee joint, which is actually the knee disarticulation. And what you do is the level of the the amputation below the tibial tuberosity is like 3 centimeter below the tibial tuberosity. If this is the point for the tibial tuberosity, so if you're performing through knee, you're not talking about the knee disarticulation. We're talking about through knee amputation. So this is the level of the tibial tuberosity. So what you do is this is the tibial tuberosity, and you go 3 centimeter below the tibial tuberosity. And above, you go at the level of both medial and the lateral malleoli. Let's suppose this is the medial malleoli, this is the level of the lateral malleolus, and the transverse incision, one is extending From the upper extent would be the loin, which is joining the joint space, or which is joining the both lateral and the medial malleoli. And the below, the, like if we talk about the distal extent, that should be 3 centimeter below the level of the tibal tuberosity. That's how you do the through knee amputations. As you could see here in the diagram, this was the level of the tibal tuberosity. You're keeping the long posterior flap. Usually, in case of through knee amputations, you perform skew flap, in which both the anterior and the posterior level, or the length of the flaps, they are equal to each other. The thing you should keep in mind is you have to identify the level of the tibal tuberosity. You have to mark 3 centimeter below the tibal tuberosity, and plus you have also you need to mark the joint line. So the joint line is extending from medial malleolus to the lateral malleolus. Let's suppose, for instance, this was the level of the medial malleolus, and the other side that was the medial malleolus, and this is the lateral malleolus. So you have to draw the demarcation, or draw the line which is joining the medial and the lateral malleoli. Plus, this was about the proximal level, and if we talk about more distal level, then that should be 3 centimeter below the tibal tuberosity. So this is becoming famous day by day, because in case of through knee amputations, the full length of the femur plus the full length of the patella, they are usually saved, and a good stump is formed, because at the end you're more concerned about the prosthesis. And if a stump is, the length of the stump is very good enough, with a good vascular supply, with more restoring to close to the nature, then a good prosthesis would be, the fitting of the prosthesis would be effective into the stump. Now, if you're done with the amputation, the next step is about the postoperative care. But before that, let's just summarize what we have studied so far. We have studied the level of the amputation. Determination of the level of the amputation is somehow very much important. The general principles for the amputations, they remain the same. You mark the you mark the lines for the flap. Then what you do is you give incision on that, through that flaps. You ligate all the vessels which comes in your way. You sharply cut the nerves, and the larger nerves, they are also ligated, but usually the nerves are not ligated, because there's chance to develop the neuromas, and then later on these neuromas, they cause severe pain in the stump. So that's why for that you sharply cut the nerves and you allow them to retract, and you do the myoplasty or the myodesis depending upon the ischemic, if it's the ischemic limb or a non-ischemic limb. So you actually the procedure or the myoplasty or the myodesis depends upon the vasculature of the limb. And at the end, what you do is you have to suture the muscular flap with the periosteum of the bone, and plus you have to bevel the bone so that the vascular supply should not be compromised, and that the edges should be very fine and very smooth. And at the end, you have to close the stump, and you bring the skin edges together, and you close the stump, and you put a drain, you secure the hemostasis, and then at the end, what you do is you put a good, you put a back slab, you wrap it with a cotton roll gauze, and then you put a crepe bandage, and you also put the epidural so that the phantom limb or the sensations of the the phantom limb, they should be wide, and the post-operative pain should be controlled. Now, you're done with the amputation and the patient is out of the theater. Now, there's some important post-operative care that should be given to every amputated limb. First of all, we're talking about the things which are necessary for the the survival of the good stump. That is to monitor the drain output, to keep the limb elevated, and you have to give a good pain relief, which is like you can control the pain with the opiate, because it's a kind of a very, very painful, especially if the nerves are irritated, because the muscles are resected, they are cut, and the nerves are cut. So there's a kind of a very inappropriate and disproportionate pain. So you have to control that. And for the choice, which is very much effective, is the opioids you're giving. then you have to take care of the limb, like you have to keep it elevated, at least on the two pillows. You have to change the dressing daily, and the thing is exercise and mobilization. This is somehow very much important, because in case of the amputated limb, if there's already a peripheral vascular disease, most likely the phenomena behind that would be atherosclerosis, and there would be when the patient would be immobilized for a very long time, there's a chance that thrombi would be developed, and ultimately that thrombus can dislodge and go anywhere and can cause the pulmonary embolism. So for that, exercise and mobilization of that limb is somehow very much important. And because if you do not exercise, the patient doesn't go under physiotherapy, then there's a chance, because nerves are already cut, the muscles are already they're already cut, so there's a chance that there can be muscular atrophy. So when the muscular atrophy is already developed, ultimately it will end up in a more proximal amputation of the limb. So that's how the post-operative care is very, very much important. At the end, there are a few things which are also important. We have to look for the complications. So actually we divide these complications into early complications and the late complications. So the early complication can be hemorrhage, and hemorrhage is usually secondarily because of the technical failure. And if you do not during the surgery, and you have not ligated the bigger vessels, even if you have not ligated the smaller vessel and you have just cauterized it, later on it will keep on bleeding. So the hemorrhage is the early complication, and you have to, if there's a kind of the hemorrhage which cannot be stopped with a pressure bandage, then ultimately you have to open it up again and you have to ligate the vessel. Then the other thing is a hematoma. So hematoma can be formed again because of the technical failure, and the vessel was not ligated in the effective way. So the hematoma would be formed, and ultimately you have to aspirate that hematoma. The other complication is the abscess, and most commonly those patients who are diabetic and the gangrene develop secondarily to the diabetes. The control of the optimum sugar levels, this is somehow very, very much important in the diabetic patients, because there's a more likelihood of the development of the infection, there's a more likelihood for the development of the gas gangrene, and more likelihood for the development of the abscess. And in case of the diabetic patients, methicillin resistant staphylococcus aureus, this is some kind of life-threatening infection, limb-threatening infection, and because MRSA is the kind of the infection which ultimately end up in cellulitis and septicemia. So there can be, you have to look up for the abscess formation as well. Go for the optimum sugar control. Go for a good antibiotic cover. This is somehow very, very much important to give. Then I already talked about the gas gangrene, and it is somehow common in the diabetics as well. And for that, obviously, you have to take care of the limb, and you have to, good antibiotic cover. But if already the cellulitis have been developed, and there is a likely chance that it will spread more proximally, then what you do is you do the debridement. You again open the stump, you debride the tissue. You sometimes, if there's involvement of the bone, then obviously the amputation level of the amputation will extend more proximally. So you have to put the patient on regular debridements. Then there can be wound dehiscence and gangrene of the flaps. Why? Because if you are not sure about the good vascular supply, let's suppose there was a peripheral vascular disease, and according to you, the level you determined was you have performed below knee amputation, and you did not check the femoral pulses, and you're not sure about the good vascular supply. So what happens in those patients, there's a more chance of the wound dehiscence, and there's a more chance of the gangrene of the flap, because usually the supply goes from proximal to distal vasculature, right? So if you have already there's a level of the resection, the stump has already been created, but you're not sure about the good vascular supply, And then what happens, it ultimately ends up in a wound dehiscence and gangrene of the flap, and ultimately it ends up in a more proximal amputation. Then there can be a deep vein thrombosis. Again, most of the time in case of the peripheral vascular diseases, the causative factor behind that is the process of the atherosclerosis. So in case of the atherosclerotic lesions, usually there's a chance for the development of the thrombi, and you have to if there is a known cause of the peripheral vascular disease, you have to put the patient on anticoagulants and antiplatelets. Sometimes you have to start in warfarin, you have to give heparin as well, like specifically low molecular weight heparin, and you have to put the patient on a prophylaxis dose of the Clexane or the low molecular heparin, and you have to overlap with the warfarin. And plus the TED stockings, the postural changes, the physiotherapy, the exercise, the mobilization, the limb elevation, these are the things you have to give to your patient post-operatively. Then there can be, again, pulmonary embolism, already discussed. There's a chance that there can be dislodgement of any of the thrombus that goes away straight to the pulmonary artery, and obviously the patient will end up in pulmonary embolism. It's a silent killer. Sometimes the patient is symptomatic in case of the shortness of the breath or dyspnea or orthopnea. But sometimes the patient, it's a kind of a silent killer. A patient remains asymptomatic and ultimately ends up in the death of the patient. So you have to post-operatively, you have to take care for the deep vein thrombosis, and you have to take care for the pulmonary embolism as well. Then the pain. This is somehow very, very much important to discuss and to take care of. For a good pain relief, opioids are the good choice, but usually nowadays there is a kind of epidural. When you're performing the surgery, you put the epidural catheter inside the wound and you again close it, and whenever the patient feels pain, you top up with the epidural anesthesia. So that's a kind good approach for the pain relief for the phantom limb. There can be bony spur formation because sometimes when you do not, beveling of the bone is somehow very, very much important, so that the edges should not be sharp and they should not actually irritate the nerves or they irritate the vessels, and they do not cause a kind of the pain. But sometimes when the edges are not beveled properly, there's a formation of the bony spurs. There can be a formation of the scar which is adherent to the bone, and there can be amputation neuromas. That's why you cut the nerves sharply. You do not ligate them, or you do not leave them as it is. You just try to cut them sharply, allow them to retract on their own, because there's a likely chance for the development of the neuron. And sometimes when there is blood supply is not sufficient, ultimately it will end up in the ulceration of the stump. So post-operatively, it's very easy to perform the limb amputation, but it's difficult to manage it post-operatively because you have to take care of all the complications. Plus, as already discussed in the beginning, it's a kind of a stress to the patient. It's a very big stress to the patient. It's not only the physical stress, it's a psychological, it's a social stress for the patient. Particularly, the patient is unable to walk, and amputation, for example, if more proximal amputation is being done, the patient is more concerned about the walking and the function is already being compromised. So what you do is you're more concerned about the psychosocial rehabilitation of the patient. So in every hospital, there's psychosocial therapists, there's psychiatrists which are available. You should entertain the patient with their services. A proper counseling sessions should be given. A proper counseling should be given post-operatively and pre-operatively as well. That they're kind of the prosthesis available in rehabilitation centers. The patient should be referred to the rehabilitation centers for the good prosthesis and for the rehabilitation, for the physiotherapy, and for the exercise. So it's not only the job of a surgeon for the amputation of the limb, but actually the post-operative rehabilitation, the psychosocial support you have to give to the patient, and post-operative complications should be dealt in a very professional and effective manner. So keep in mind the complications early in the leg complication. They can be hemorrhage, there can be hematoma, there can be abscess formation, there can be gas gangrene. You have to give a prophylaxis dose for the control of the DVT. You have to look for the pulmonary embolism. A good opioid analgesia for the pain. Epidural analgesia should be placed in the stump to give a more sustained relief of the pain. Topping up with epidural anesthesia. This is somehow important. And while you are performing the amputation, the restoration of a good vascular supply, that's also very much important. Otherwise the stumble goes into the ulceration and necrosis. So that's all for today's lecture. We have discussed a lot of things. We talk about the determination level. So the go-home message today is to properly determine the level of the amputation, to properly counsel the effects and for the rehabilitation of the amputated limb and the level of the amputation. And obviously you have to follow the basic principles, because the basic principles for all the amputations, they remain the same. Only the differences between the flaps, the level of the amputation, that's important. And a good post-operative care that can help in the upbringing and the rehabilitation and the restoration of the good function of the limb. That's all for today. So keep watching sqadia.com. Thank you.